Hello, I'm Brittany Gankars. I'm a prenatal genetic counselor at UConn Health, and this talk was originally given at our monthly genetics seminar at UConn, but I'm also recording it for the students at the Bay State Genetic Counseling Program. So hopefully this can be a tool for continuing education for both the genetic counseling students and anyone who wasn't able to be at that talk and is willing to listen. So to introduce myself for anyone who doesn't know me, like I said, my name is Brittany, and today I'll be talking about prenatal exome. I'm a prenatal genetic counselor at UConn. I've been working here for about 5.5 years. And we are delving into a brave new world of prenatal exome sequencing. So this talk will be in a couple parts. We'll start by talking about exome sequencing in general. Then we'll talk about some of the research that's been done on prenatal exome sequencing. I'll walk you through 3 case series. We'll talk about some practical considerations for application, and then we will review some new recommendations that just came out about prenatal exome sequencing. Those recommendations came out as a joint statement from the International Society for Prenatal Diagnosis, the Society for Maternal Fetal Medicine, and the Perinatal Quality Foundation. They timed very well with me choosing to present on this topic. And I'll actually kick us off by talking about my personal experience, my personal very limited experience in prenatal exome sequencing. So I have 2 cases to talk about that I was involved with. The first one is a case of a couple who presented to me for genetic counseling after termination of their pregnancy. And they presented to me quite a ways after that, about more than 6 months, I would say. And their fetus had ambiguous genitalia, microcephaly, and abnormal serum values. I'm sorry if you just heard my dog snore, because that just happened. And in that pregnancy, the chromosomes were normal. The couple had Smith-Lemli-Opitz testing, which was negative, and microarray had revealed a variant of uncertain significance that was found to be paternally inherited. This case was very interesting in that it actually was very suspicious for Smith-Lemli-Opitz. So there'd been a lot of the prenatal findings that would go with that diagnosis: the ambiguous genitalia, the abnormal maternal serum values, the microcephaly. It really did look very suspicious, but their testing was totally negative. If you're a genetic counseling student and you're not familiar with that condition, it's a recessive condition that can cause many of those features. And the DNA testing on the fetus had revealed no mutations whatsoever. So the fetus wasn't a heterozygote, there were no benign polymorphisms, it was totally negative. And that couple came to me thinking that the VUS was causative of what had happened in their pregnancy. And upon reviewing it and knowing that it was inherited from the dad, I really wasn't convinced of that. So they were hoping to pursue assisted reproduction to prevent having another affected child, and I felt like we couldn't do that on the basis of the VUS alone. So I recommended exome sequencing on remaining fetal DNA to assess for single gene disorders. Case number 2 was a case of hydrocephalus that was seen on 19-week ultrasound in a female fetus. I mentioned female here for the genetic counseling students' sake, because you may or may not know that there's an X-linked form of hydrocephalus that is caused by single gene mutations. But of course, as an X-linked recessive condition, that would be suspected more in a male pregnancy, and this pregnancy was female. There were no other ultrasound anomalies seen. The patient had a negative family history, and she decided to terminate based on the ultrasound findings, but she did desire testing to get information about her recurrence risk. So this is how these 2 cases ended up. My couple whose previous pregnancy had the ambiguous genitalia, the lab did have DNA saved from the patient's amniocentesis. They had enough DNA, which is a big deal because you do need a lot of DNA for exome sequencing. Another success is that the patient's insurance was billed for this testing on her terminated pregnancy, and her out-of-pocket cost ended up being $0. So that's pretty amazing. Dr. Tucker talks about that event like seeing Bigfoot, so that was a small success for me. Because what wasn't successful was the exome sequencing revealing a diagnosis. So that exome sequence was totally negative. It was the most normal exome sequencing I've ever looked at. So that was so discouraging for me. It really seems like this baby had some kind of genetic diagnosis, and we've pulled every tool in the book, and we haven't found out what it is yet. In the fetal hydrocephalus case, the patient had a D&E, which, if you're a genetic counseling student, you don't know what that is yet. It's a second trimester procedure for termination at 19 weeks. Fetal tissue was sent for microarray as the first step in testing, because if we could get a diagnosis with the microarray, there would be no point in breaking out the fancier testing with the exome sequencing. And then DNA was sent from the lab that did the microarray to the lab that would perform the exome sequence when normal microarray results were had, which they were. And I felt pretty good about getting that DNA sent from one lab to another, because it meant that the patient didn't need to have an amniocentesis. It meant that we didn't have to send fetal tissue all over the place. And we did send samples on mom and dad to the lab that did the exome sequencing to accompany the sample. So actually, for both cases I've been involved with, we were trying to do trios, so both parents plus the fetus. And then we found out the DNA from that fetal hydrocephalus case was of insufficient quality for exome sequencing, so they weren't able to do the exome sequencing at all. So that was discouraging. I feel like I learned a lesson in terms of trying to get that DNA sent from one lab to another, but we didn't end up getting any information from that case. So those are my sad stories about how I've been personally involved in exome sequencing. I tried, and I haven't been successful yet. So next we will talk about let me go back there. Next we'll talk about genomic sequencing in general. And this presentation is definitely not comprehensive about genomic sequencing. I feel in a way this presentation is a little bit like genetics provider who doesn't routinely do this tries to make sense of this and how it fits into her practice. We'll start a little bit with exomes by the numbers. When I gave this live in genetics seminar, I was hoping to play a game where people would guess, what these numbers are, and my formatting didn't work, so we didn't get to play our game. So when we think about exomes by the numbers, and I love numbers and I love trivia, and hopefully one day at some kind of professional conference you'll win trivia based on this slide. So when we talk about the number of genes in the human genome, it's understood to be about 20,000 genes. There's additionally 37 genes in the oft-forgotten mitochondrial genome. In the human genome, there are about 180,000 exons. And the percent of the genome that is the exome is about 1 to 2%, so a tiny little proportion. The percentage of the exome that can be reliably sequenced with our current techniques is 95%. The diagnostic utility of exome sequencing, which is to say when the patient is suspected of having a genetic diagnosis and other tests have not revealed the diagnosis, what is the chance that exome sequencing will identify what that is? That yield is about 20 to 30%. And then we ask, well, if we do whole genome sequencing, so we get out of that 1 to 2%, and we look at the whole genome, what is our yield in that case? And it's about the same right now. It's about 20 to 30%. And that likely reflects our lack of interpretation ability right now outside of the exome. And then how many labs offer prenatal exome sequencing in the US? That number right now is 3. All right, so let's look at the genome and its different parts. So at the top of this slide here, we have the genome. And usually when we talk about the genome, we talk about it as if it were just this nuclear DNA, but there is the mitochondrial DNA as well. That mitochondrial DNA has 37 genes and a regulatory region. 13 of those genes make enzymes for oxidative phosphorylation. And then the nuclear DNA has about 20,000 genes as well as intergenic sequences. And in a gene, we've got our introns and our exons being the part that is expressed. That's the little phonetic trick I've always remembered it as. So when we talk about exon sequencing, we are sort of staying, oh, where did my arrow go? We are staying down here in the exons. We're looking at the part of the genome that is expressed into protein, the exome. So even though that's only 1 to 2%, our current understanding is that that's sort of the workhouse of the genome. And this is a sort of flow chart showing how whole exome sequencing is done. So starting with extracting genomic DNA, preparing a sequencing library, enriching for the exome. So, kind of enriching for those exon pieces so that those are what we're looking at. And the top half of this flow is kind of the sequencing part, and then the bottom half is more the interpretation part. So the interpretation part is really the, so to speak, tricky part of this exome sequencing. We can see variants, but we need to know what they mean. These are some of the interpretation tools that are used. A lab might use population databases such as the 1000 Genomes project, the SNP database. They might use curated variant databases such as ClinVar, published literature, as well as unpublished in-house laboratory data. So that's an area where you'll see variation from one lab to another. Not that a lab shouldn't use the data that they've been accumulating, but you can see that one lab might interpret a variant a little bit differently based on some of that unpublished data than another. And finally, predictive tools, tools that will predict how a variant will change the function or structure of a protein. An example of that would be something like polyphen. So with these interpretation tools, there is definitely a human element to it. So you can get variation in interpretation depending on who's doing the interpretation. And that's an area that's really difficult for patients to understand. It can be hard for us to understand as clinical genetics professionals as well. But there's definitely that interpretative element to all this. And if you're a genetic counseling student, I do have at the end of this presentation some resources. And one resource that's really useful in understanding this flow of exome sequencing is the paper, the Biesecker paper. It's the first one that I list on my resources slide. If you go to that paper online, you can actually look at the interactive graphic, which is really, really useful. I watched it several times in preparing this presentation. And what makes this genomic sequencing more feasible and more accessible is the plummeting cost. So it's pretty impressive to see a range of $100 million to $1,000 on the y-axis when we talk about the cost per genome. So we're kind of hovering right around that $1,000 genome, but like I talked about with the interpretation, one sort of catchphrase that's used is that it might be $1,000 genome, but it's still $1 million interpretation. And there are some disorders and genetic variations that are not reliably detected by exome sequencing. So exome sequencing is not the genetic holy grail. It is not the test for everything. Some of the examples of those disorders not reliably identified by exome sequencing are listed here. So variations like imprinting errors and uniparental heterodisomy, so two chromosomes that are both maternal or paternal in origin, won't be reliably detected by exome sequencing. And examples of that include Beckwith-Wiedemann and Prader-Willi syndrome. Also, mutations that are in highly repetitive regions of DNA, like repeat expansion disorders. So this will include our well-known Fragile X syndrome, but also many other conditions like myotonic dystrophy and spinal bulbar muscular atrophy. And a resource I found really useful about genomic sequencing in general, but also about some of these disorders, was the Gene Review's educational piece on genomic sequencing. The supplements really had good information about what disorders are caused by imprinting errors and what disorders are in highly repetitive regions of DNA, or, as my next bullet lists, what disorders are in genes that have highly homologous gene family members or pseudogenes. But all those lists were actually quite long to me. I wasn't familiar with, how many disorders fit into those categories. Exome sequencing also won't detect structural chromosome variations, and it won't be able to detect copy number variants like insertions or deletions greater than 50 base pairs. So that also includes a very well-known genetic disease, spinal muscular atrophy. So, as you can imagine, when we're doing such a comprehensive genetic test, the consent is really tricky. And this is definitely not comprehensive about what consent for exome sequencing needs to take into account. Some of the other counselors and Dr. Tucker and I do a workshop with some of the medical students during what they call home week in their third year of medical school. And we walk them through a case where a family's consented for whole exome sequencing. They're looking for an explanation for their adolescent's cancer diagnosis, which is suspicious for a hereditary cancer syndrome. And instead, they find out he has long QT syndrome. So making sure that patients have really thorough pretest counseling is so important when we're doing such a comprehensive test. Some factors to consider in the consent, and then later on we'll talk about how there's additional considerations if we're talking about this on a prenatal basis, is the likelihood of getting an informative result. So not overselling this kind of testing, which is sort of very tempting to do. What the meaning of a negative result means, so that does not rule out the potential for a genetic diagnosis. Also talking about things that we can find that we're not necessarily looking for and that we don't necessarily know how to interpret. So things like variants of uncertain significance, secondary findings, which I'll speak more about, adult onset conditions, and then the implications for other family members. So when we do testing in genetics, we're never finding out information about just that person. We're finding out information about their family members as well. So in terms of secondary findings, so what we can find in addition to what we're looking for, of course, a wide variety of adult onset genetic conditions might be identified during exome sequencing. In 2013, ACMG published recommendations of genes that should be analyzed and reported on when exome sequencing is done. And then in 2016, they updated that list. So these recommendations were a big change to the status quo because conventional wisdom has been that we don't test children for adult onset conditions. And that is literally exactly what this advocated for. Now, patients or their parents may opt in or out of those secondary findings, although a poster I saw at the 2017 NSGC meeting showed that the number of patients opting out of learning those findings is significantly decreasing. And that was from one particular site who's been offering exome sequencing, but they noticed a pretty significant trend that whereas when they started exome sequencing, a significant proportion of patients were opting out, that number's been steadily dropping. And when patients do opt out of these secondary findings, and in a lot of the exome literature, secondary findings is almost used as like a proper noun to speak about the specific ACMG recommended findings. When patients opt in or out of those, they're opting out of that defined list. And they also do have to opt out of either the whole list, they have to opt into the whole list or out of the whole list. They can't pick and choose disorders. they're not opting out of finding any unclear finding from their exome sequencing. So lovely as that would be to be able to say, I don't want to hear anything uncertain, that's really not an option with this kind of testing. Opting out would be to say, I don't want to learn about these disorders. And I've thrown up some tables with these disorders. I'm not going to go through these in detail, but you'll see that a lot of them are hereditary cancer syndromes, hereditary breast and ovarian cancer being at the top there. Also things like FAP, familial adenomatous polyposis, von Hippel-Lindau, retinoblastoma. Some of these are childhood onset, like retinoblastoma, for example, and FAP, or tuberous sclerosis complex at the bottom. But some of them are adult onset as well, like hereditary breast and ovarian cancer. And these secondary findings also speak to other family members. From a prenatal side of things, if we did identify a fetus with a BRCA mutation, that tells you something about mom or dad. And honestly, if you test mom or dad and they don't have that mutation, that might tell you something about non-paternity. So really, what counseling boat do you want to be in with the difficult news in that situation? The vast majority of these secondary findings are also autosomal dominant, as you'll see in the inheritance. So it really is giving us powerful information about other family members if we see one of these things. The list just goes on here. There's hypertrophic cardiomyopathy, the vascular type of Ehlers-Danlos, familial hypercholesterolemia, long QT, which is what we used in our case for the med students. So the point of these specific conditions is that they're highly medically actionable. So that if you get a diagnosis of one of these, there are things that you should do for your health. For example, if you get a diagnosis of long QT syndrome, there's the risk that you could, die. So that's supposed to be the goal of these reported secondary findings, is that they're very serious and they're things that for people's health and well-being would want to know about right away. So that can also explain why more parents are opting into learning these findings, because to opt out is to take kind of a risk that there's something very serious that you're not going to learn. So as you can see, just exome sequencing by itself without bringing the prenatal exome into things is quite a lot. You're testing for a lot of genetic information. You have a very high potential for uncertainty and lots of factors to consider, and certainly a consent process that needs a lot of care. But like every test that can be done in pediatrics, at some point someone asks, can we do this to a fetus? Okay, so now let's dig into some of the research that's been done on exome sequencing on a prenatal basis. I'm going to walk you through 3 case series. 2 are from 2015 and 1 is from 2017. 2 of these were also done on a research protocol and 1 was done on a commercial basis. So this first case series is a series of 24 fetuses who had exome sequencing on a research protocol for ultrasound abnormalities. And they are reporting that exome sequencing provided a definitive diagnosis in 21% of cases, or 5 out of the 24. So this is N is small, of course, as it's going to be in all 3 of these case series, but this is comparable to what we're seeing as the yield in a postnatal population. So that's very interesting. The exome sequencing also revealed some kind of finding in 5 additional cases. So I'll speak about both those diagnostic findings and those additional findings. One of their inclusion criteria was isolated increased nuchal translucency, and that kind of made me, I don't want to offer exome sequencing for isolated increased nuchal translucency. If you do a prenatal rotation, you'll understand more about that very soon. But I just wanted to give the reassuring news that no significant findings were found in those cases where that was the only indication. So let's walk through the 5 diagnostic findings. if you look at the original research paper, this is a modified version of their table 1. So we can see that in these 5 cases, we have 5 diagnoses, including Milroy disease, hypophosphatasia, achondrogenesis, Freeman-Sheldon, and Barrister-Winter. So what's the theme here? There kind of is no theme. We could pull out the hypophosphatasia and the achondrogenesis and say that a little theme that emerged was skeletal dysplasias, and we'll see skeletal dysplasias in the 2 further case series as well. But these are kind of all over the place. If you're a genetic counseling student and you're like, I don't know what any of those things are, a lot of genetic counselors don't either. So Freeman-Sheldon and Barrister-Winter were totally unfamiliar to me. Milroy disease is only familiar to me because of a particular case that I had. So this is kind of all over the map. Actually, Barrister-Winter, there's per genetics home reference, there's only been 50 reported cases in the literature. So if that one's unfamiliar to you, you're definitely not, it would be more unusual if that was familiar to you, really. And we can see that 4 of these conditions were autosomal dominant. 2 of those were inherited, the Milroy disease from mom. That's sort of the most benign of these diagnoses. So Milroy disease is an inherited lymphedema, so it causes lymphedema or swelling, mostly of the lower limbs, but it's not associated with things like intellectual disability. Some people who do have mutations aren't symptomatic, so it doesn't have complete penetrance. That's definitely the most benign of these 5 conditions. And then this Freeman-Sheldon is an inherited distal arthrogryposis. In this case U here was sort of a case where they saw these findings in the fetus. This flexed neck, micrognathia or small chin, talipes, which is clubfoot, and clenched hands. And then they looked at Dad and said, Dad's kind of unusual looking. And both the fetus and the dad had the same mutation. What was interesting about the dad is he didn't have any joint findings like you might expect for an arthrogryposis condition. So like many things, so often when we start to do this molecular testing, we sort of expand our phenotype. And we see the hypophosphatasia is autosomal recessive, so that pretty dramatically informs the couple's recurrence risk, which would be 1 in 4. And then these are the uncertain findings. So what I think is interesting is that it is actually a 1-to-1 ratio. For every diagnostic finding that was made, an uncertain finding was made as well. That has to be worked through on the post-test end of things. So this top case V is probably the most confident of the uncertain findings. They saw 2 mutations in this gene, this C5 ORF42 gene, and that's been associated with an orofacial digital syndrome that has recessive inheritance. So those things go hand in hand. What was, I think, uncertain about this is that one of these mutations that was identified in this case was a nonsense mutation, and the other one was a synonymous mutation. So I think they're categorizing this as more uncertain because of that synonymous mutation, but that synonymous mutation is thought to decrease splicing. Then these next 2 cases, M and N, are cases where they found one variant in a gene that's associated with an autosomal recessive condition, but didn't find another variant. But in both these cases, the presentation of the fetus does match up to the clinical presentation of these disorders. In case M, a ciliopathy, and in case N, Fraser syndrome. So this sort of speaks to one of the limitations of exome sequencing, which is gene coverage. The authors point out that for both of these genes, there was sort of less than ideal coverage with the sequencing. So for the, let me just orient myself. I believe for the ciliopathy, they had 80% coverage of this gene. And for the Fraser syndrome, they had 87% coverage for this gene. And they tried to do, deeper sequencing. They tried to look for a second mutation, and they just could not for the life of them find one. So these diagnoses are a little bit up in the air because they're not molecularly confirmed, but the presentation in both these cases does sort of clinically match up to those. And then finally, for these last two cases on this table, cases R and W, we see findings that have nothing to do with the prenatal findings. So in case R, there was a cardiac defect, a ventricular septal defect, and a large nuchal translucency, and the fetus had an NF1 mutation, so totally unexpected. And then in case W, the fetus was diagnosed with Wilson's disease, which has no prenatal presentation, so a true incidental finding. And then these are some cases where no mutation was identified. So similarly to my first experience with fetal exome sequencing, there is a definite ultrasound finding and yet no indication as to its origin from a molecular standpoint. So some of these were really surprising to me. Holoprosencephaly would have been one where I would have bet that exome sequencing would have found something. Omphalocele was also got no diagnosis. Some things like the isolated clubfoot, I might have suspected would be negative, or the mild ventriculomegaly. This case, the short limbs with the stippled epiphyses and the flat face, they thought was suspicious for chondrodysplasia punctata, but no mutations were identified. And then also on this negative list, the 5 cases of isolated and large nuchal translucencies didn't have any exome findings. All right, so that was case series 1. Case series 2 comes to us stateside from the US. Oh, I don't know if I mentioned that last case series was from the UK. This one comes to us from the US. It was also published in 2015. It was actually published in the same edition of Prenatal Diagnosis as the last one. This is also a little different. This is testing done on a commercial basis, not a research basis. And it's a retrospective study of the first 7 cases referred to Ambry Genetics for fetal exome sequencing. I call this paper the more than half paper because they include that in their title. They boast we identified diagnostic mutations in more than half of our cases. In this case, N equals 7. So they identified mutations in 4 out of 7 cases. So that more than half made me chuckle. So these cases are from 2012 to 2014. So these are definitely very early adopters of doing these mutations or doing this sequencing on a clinical basis. Because fetal exome sequencing was not at all in my radar in 2012, at which point I was fresh out of graduate school. So a couple characteristics of these 7 cases. They were all fetuses with multiple congenital anomalies. They were all between 19 and 24 weeks gestational age. All of these fetuses had both normal chromosomes, and 5 out of the 7 had either normal microarray or an uncertain microarray. And I'm going to talk about that uncertain array a little bit more when we start to get into the findings. All of them were sent as trios, so the fetal DNA plus both parents. The trio is just really far superior. Right now it's basically required if we're going to do this kind of exome sequencing to help with the interpretation. All of these are non-continuing pregnancies, so there's no ongoing pregnancy. They were all pregnancies that were either fetal demises or terminations. And then finally, 6 out of 7 of these cases were cases where the family had more than one affected pregnancy. So one thing we're seeing in this paper is that when we use a new test or use a test in a new application, we usually start with a very sort of enriched population. So since the majority of these families had had a previous pregnancy, these cases were really, really suspicious for having some kind of genetic diagnosis. So something similar is when we started BRCA testing, those first patients who did BRCA testing were those with just, raging family histories of breast cancer. And then as we start to gain more experience in doing a test or using it in a new application, sort of the less strongly suggestive patients start to take up that test. All right, so these were their four, more than half, their four pathogenic findings. So again, we do see skeletal dysplasia jump out at us. There was a diagnosis of osteogenesis imperfecta type 2, and that family was actually the only one without a previous affected pregnancy. And that makes perfect sense because that is a dominant de novo condition. So it makes sense they had never had an affected pregnancy, and they would be at very low risk to have a subsequent affected pregnancy. And I think it also makes sense that these skeletal dysplasias are sort of a theme in these case series because they're ones where there would be a lot of prenatal ultrasound findings. We've actually made 2 diagnoses of OI type 2 here at UConn, not using prenatal exome sequencing, but using a skeletal dysplasia multi-gene panel. And in both of our cases, they were very similar to this top case in that it was a novel mutation, one that's never been reported before, but one that makes sense for the perinatal lethal type of osteogenesis imperfecta in that it disrupts the glycine in a very canonical glycine XY tripeptide that makes up collagen. And if you're a genetic counseling student, you might not perfectly be able to follow along with that, and that's okay. But only that this top case is kind of similar to what we've experienced in the last couple years, but we've been making those diagnoses through a multi-gene panel and not exome sequencing. Case 2 was glycogen storage disease type 4. And glycogen storage diseases in general are a really large umbrella. There's a lot of subtypes, and then each subtype has many subtypes. So for glycogen storage disease type 4 in general, there is a perinatal lethal subtype which corresponds to these prenatal findings that they were seeing. So there were lots of ultrasound findings in this case. There was IUGR, intrauterine growth restriction, reduced fetal movement, contractures, pleural effusions, cleft palate, facial dysmorphism, and a fetal demise. So as we discussed a little bit when I did this live for our genetics seminar, glycogen storage disease type 4 is never something you could pull out from these ultrasound findings. You can tell by the number of findings and by the seriousness of the findings that there's something serious going on, especially when a family's had more than one affected pregnancy. You can say pretty confidently this seems to be genetic, but you're never going to be able to say like, oh, we're seeing these ultrasound findings, glycogen storage disease type 4. So that sort of nods to the benefit of doing something like fetal exome sequencing because you'll never be able to go gene by gene and identify something like this. And then in case 3, orophacial digital syndrome type 1, an X-linked recessive condition, makes a lot of clinical sense because this family had a similarly affected male pregnancy prior to this pregnancy, and this fetus was also male. This is not the first time we've seen an orophacial digital syndrome as well, so that might be a little bit of a theme too. And then an autosomal recessive condition diagnosis of a fetal akinesia deformation sequence, which I believe was either one of those fetal akinesia syndromes is in either the last series I just told you about or in the next one. And we're seeing there's more recessive conditions in this case series than in the last one. And since all these families, except for this top one, have previously affected pregnancies, that does make a lot of sense that we're seeing more recessive conditions represented in this population. What's really rich in this article is the way that the authors describe sort of identifying the mutations and, what makes them think that what a mutation is pathogenic. That part of the article is really, really interesting. So some of those factors that they use in evaluating variants are, is it present in the databases, such as 1,000 genomes or the SNP database? Is there complete conservation in vertebrates? And this picture of the lizard that's on this slide is actually because one of the things that in one of the tables where they say, is there complete conservation in vertebrates? The answer for one of them is yes, just not in lizards. So that's how the lizard got his picture on this slide. Has the mutation ever been reported before? Which for a lot of the variants they identified, the answer was no. And then what do the prediction tools say about it? So polyphen, like I spoke about, and also SIFT. Both of those predict how an amino acid substitution or a variant affects the function or the structure of the protein. And then there were also negative cases. So those negative cases, included a male fetus with congenital heart defect, renal and lung abnormalities, and dysmorphic features. And that family had had a similarly affected male pregnancy as well as recurrent pregnancy loss. So, that's one where, like my first case, why didn't we find anything? There was also a female fetus with congenital heart defect, heterotaxy, and a left-right patterning defect, where the family had had an affected male pregnancy with a complex congenital heart defect, and the mom had bicuspid aortic valve. So in that case, it's kind of hard. Of course, we have very incomplete clinical information about the cases, but, it's kind of hard. As a counselor, I might say, are these related? Are these not? It's hard to say. And then also a male fetus affected with renal abnormalities where the family had had a previously affected pregnancy. Some other notable findings in these cases, or I should say notable findings in these cases. This paper was frustrating. It mentions that 4 of the 7 cases had notable findings, but it doesn't talk about what they are. Potentially because maybe they were trying to get another publication out of it. So those notable findings were one where there was not a lot of clinical overlap or where the gene involved was inconsistent with what the phenotype was, where there were variants identified in only one allele of a recessive condition, or where there were variants classified as most likely benign. So they had 4 cases like this, and they say that they don't tell you which case it is, but they say that 2 of those cases were in those 4 positive findings, but then that the other 2 were in 2 of those 3 negative findings. So in this case series, for 6 out of the 7 cases, you would have information to work through on the post-test counseling side of things as the genetic counselor. So again, we're getting a 4-to-4, a 1-to-1 ratio of uncertain findings as there are to pathogenic findings. And this case series did not include those ACMG secondary findings at all. And in the last case series that I'll walk you through, this is a much newer case series. This is from 2017. Sorry, Siri just started listening to me. She's such a creep. Anyway, this is from 2017, and this is also a case series from the U.S. This is one done on a research protocol. It's from the University of North Carolina at Chapel Hill. And these are, again, a series of non-continuing pregnancies that had multiple congenital anomalies and normal karyotype and microarray. So they included patients who had lethal anomalies and were continuing their pregnancies, patients who had chosen to terminate, and fetal demises. They started by recruiting from current patients, and then they did open up their recruitment to patients not receiving their care at UNC. Some of their patients were self-referred or referred by other clinicians, and they ended up with a total of 15 trios. I'm sorry, my dog is barking. And 2 of these cases were actually enrolled 5 and 10 years after their pregnancies. So I think that speaks to just how motivated or how desperate a family can be to receive a diagnosis. And as part of their research protocol, patients were informed of the following. They were informed of any diagnostic findings with the potential to explain the fetal phenotype. They were notified of any medically actionable findings in a parent. And they were also informed of carrier status for a significant recessive disease if both parents were seen to be carriers. And just of note, this N ended up being 0. So they didn't have any parents like this where carrier status for a disease not related to the phenotype was disclosed to the parents. So for their results, they broke their results into 8 different categories, which when I read that, I'm already overwhelmed. But they had categories of positive, uncertain, and then, of course, a negative category of results. And for the positive results, they had definitive, probable, and possible. Their possible positives have a really defined definition, though. They're defining possible as a recessive disease where both a pathogenic mutation and a variant of uncertain significance are found. So that's what possible positives are in these cases. For the uncertain types of results, they have variants of unknown significance, autosomal recessive heterozygotes, so similar to some of the uncertain findings we've been discussing in other cases where one mutation but not 2 are found in a gene associated with recessive disease. Uncertain contributory, meaning that they're not able to say that it's definitely contributing to the phenotype. And then finally, uncertain other, which I'll speak about. And they're resulting that whole exome sequencing provided a diagnosis or possible diagnosis in 7 of their 15 trios, which is a yield of 47%. So we'll start with their positive findings. Skeletal dysplasia once again, OI, and a de novo mutation. They classified this as probable. The probable rationale is really interesting in this case because this mutation they identified had been reported before, but it had been reported in a father-daughter pair with type 1 OI. And in this case, they were seeing shortened long bones and bowing on ultrasound, so that wouldn't correspond to a diagnosis of type 1 OI. So though they feel this is the diagnosis, that's why this is probable and not definitive. They also identified scalp ear nipple syndrome in the second case, which is one of those diagnoses where you're thinking, please tell me I don't have to say that to the family. Another fetal akinesia sequence, but this one identified in a different gene than in the last case series we talked about, MUSK. And for the genetic counseling students, if you're not familiar with what KCTD1 are and MUSK are, nor am I, just off the top of my head, call 1A1, osteogenesis imperfecta. You'll know that soon. But again, like the other case series, this just shows very esoteric diagnoses. And this fetal akinesia sequence is recessive, so is one with a significant recurrence risk, whereas the scalp ear nipple syndrome is from a de novo mutation. And this fetal akinesia sequence is one of their possible positive findings, meaning that one of the mutations was a disease-causing variant, and the other one was a VUS. But the clinical presentation did fit with the diagnosis. And then their next 3 positive findings, short rib polydactyly with this DYNC2H1 compound heterozygote. And this is interesting. We actually did see this gene before. It was in the first case series, and at the time was one of those one variant was found but not the other situations. In this one they did find 2 variants, so interesting to meet this gene again. Then 2 mutations in this gene, PIEZ01, which they say has been recently associated with a lymphatic dysplasia. Makes sense with the non-immune high drops that was seen prenatally. This was also one of those possible findings. The only positive finding that they categorized as definitive was this Meckel-Gruber syndrome diagnosis, because both of the mutations identified for this recessive condition had been established as disease-causing mutations. Then we move into their uncertain findings, of which there are 4. So again, we're seeing lots of uncertainty along with any definitiveness. This top one is primordial microcephaly dwarfism, 2 mutations in this RTTN gene, for a fetus that had a malformed calvarium, which for the genetic counseling students is the part of the head that's not the jaw. A small head, growth restriction, cerebellar hyperplasia, and absence of the corpus callosum. This next one was a family these next 2 are both those, I think of them as like recessive mismatches. So 1 mutation when there ought to be 2 based on the clinical presentation. This first one in a lethal multiple pterygium syndrome, for a family that had 4 affected pregnancies. So a family that's really suggestive of something recessive. Not seeing another mutation is a little frustrating. And then a single mutation in PKHD1 associated with autosomal recessive polycystic kidney disease. And for both of these 2, the authors recommend doing deletion duplication analysis in those genes, because if we recall, one of the limitations of exome sequencing is that we're not going to get gene deletions and duplications. And then this final case is very interesting. It's that uncertain other case, and it's categorized as other because this gene is being proposed as a new or a novel candidate gene for what they're seeing. What they were seeing is a complex cardiac defect and renal abnormalities. This gene has not been associated with disease in humans, except for, of course, this instance. But there are some animal models that show that it's embryonic lethal, and it is known to be involved in vascular development. So from all of our genetics, sciencey side, this is just so interesting, to be able to identify a novel gene that might be involved in what's going on for this poor family. Though at the same time, it is really complicated for post-test counseling in terms of counseling the family, what does this mean going forward for them? Since this was a de novo mutation, it might not mean much. Their recurrence risk is likely very low. But are they going to be able to do prenatal diagnosis for this mutation in a gene that's never been reported before? They wouldn't be able to do an assisted reproduction option like PGD for a de novo mutation. So even though this is so fascinating, it's still a difficult one to help the family manage and move forward with. And then finally, these were their negative findings. There was a case of non-immune hydrops, a fetus with short and long bones, renal agenesis, heterotaxy that had a complex heart defect, and omphalocele. Omphalocele is something that's popped up in a couple of the negative cases, which I think is interesting. And then a family that had multiple pregnancies with GU abnormalities. Some other findings, the turnaround time averaged 28 days from when sequencing was done. So that's not 28 days from start to finish, but what's so striking about that is one of the 2015 papers had a turnaround time of 23 weeks. So it's totally dramatic how much that shortened up in 2 years. They had one ACMG secondary finding. It was familial hypercholesterolemia, which I'm going to go ahead and say that's probably the secondary finding you'd pick if you had to have one. And it was for a parent who knew that they had high cholesterol and knew that they had a family history of it. There were no couples who were carriers of recessive disease that wasn't related to the phenotype. And all patients did express in their post-test survey that they felt that it was a good idea to have the testing. So this was a highly selected group, of course. So This is a group that was motivated to be part of a research study. 2 people who waited 5 and 10 years after their pregnancy loss to do testing. It was also a group that was filled with many highly educated people who had a better than average baseline or better than average knowledge of genetics just at the baseline. 40% had incomes of over $90,000. So this is definitely a very selected for group, but it is a good sign that all the patients felt like this was a good decision to enroll in this study. All right, so next we'll talk some practical considerations for the application of this testing in a prenatal setting. With prenatal testing, we do get some unique, we do have some unique points to consider. One strong consideration is definitely the gestational timing of when this is happening. And I have a little flow chart on the next page to talk through that. Another point to consider is identifying good candidates for testing. So which patients is this best for? I think that one big question is this best used in cases where the pregnancy is continuing or where the parents are choosing to interrupt the pregnancy or when the pregnancy is interrupted by something like fetal demise? For a family that's going to continue the pregnancy, I think it's worthwhile to ask if this is a good idea because we can always do testing after their baby is born. There's no testing we can do prenatally that can't be done easier and better and potentially more targeted when we have more clinical information on a postnatal basis. We also have to consider, are there multi-gene panels that can be used instead of exome sequencing? That helps relieve some of the issues related to secondary findings and incidental findings, and you also get better coverage of those highly suspicious genes. For example, I think all of the skeletal dysplasias that were identified in those 3 case series I presented could have been identified using a prenatal skeletal dysplasia panel that's clinically available. Another big point to consider is how are we going to use this information in a forward way? And I think this is one of the most complex points to all this is that all these case series looked at non-continuing pregnancies. So a really significant motivation for these families was using this information for having future pregnancies. But a lot of this uncertain information is really difficult to use for prospective information and to apply prospectively. So in some of these cases where there's variants of unknown significance, how confident are we that if we, say, do pre-implantation genetic diagnosis for those variants, that that's really going to prevent the family from having another affected pregnancy? With conditions that arise de novo, we also don't have that option of pre-implantation genetic diagnosis at this point, though the good news for those is that the recurrence risk is very low. And in some of these very rare genes, how feasible is it going to be to order clinical prenatal testing for mutations in those genes through CVS or amniocentesis? So it would just be a very frustrating place to be if we now had this information from a previous pregnancy and we either didn't know how to use it prospectively or we were in a place where we couldn't use it prospectively. Another point is the need for parental testing. So, all these case series looked at fetal DNA within the context of a trio with both parents. And that seems to be really just by and large the preferred way, if not the only way right now for this on a prenatal basis. But that also brings up a lot of issues related to consent. Some of the nuances that I'll point out between the different labs that do this testing are how the parental information is used. So is it used only to support the testing on the fetal DNA? Or are they getting separate information on mom, dad, and fetus? To talk about gestational timing, this slide is kind of me thinking out loud about where this fits into our sort of sequence of prenatal events right now. So to start at the top, we have first trimester ultrasound. That 12-week ultrasound is kind of a first indication of like, hey, something could be wrong. And if you're not in prenatal clinic right now, or you haven't had a lot of material on prenatal genetic testing for the genetic counseling students, don't worry too much about, I don't know all this. That's okay. You're definitely on the cusp of learning it. So say we are able to have a patient who we get early on, between 11 and 13 weeks, and they have an abnormal ultrasound and decide to pursue CVS. We might be getting karyotype and microarray information between 13 and 16 weeks. And then if that's normal and we're going to reflex to whole exome sequencing, we're looking at a 16-week to 19-week timeline for results. So we're well into the second trimester, and that's sort of, I don't want to say that's an ideal scenario, but that's a very, optimistic scenario in terms of getting the patient very early in pregnancy. A more realistic situation would probably be seeing multiple congenital anomalies on second trimester ultrasound, and that's happening between 18 and 20 weeks of pregnancy. So then by the time we get our karyotype and array, we're at 21 weeks. And then for about 3-week turnaround time that the prenatal exome labs are advertising, we're looking at getting this information between 22 and 24 weeks. And in terms of pregnancy management decisions, this is just a really crummy timeline. From where I'm speaking in Connecticut, our legal limit of termination is 23 and 6. It's not always easy to access termination at 23 and 6. I have very few providers who do termination at that late end of the legal limit. And if a patient is pushed over the 24-week mark, the options for termination nationally are just very, very limited. Another factor I'll be talking about is just the cost of all this testing. And at this point, to pursue whole exome sequencing prenatally, you're going to be spending several $1,000s as a patient. And then if you're doing that and pursuing third trimester termination, you've pretty much spent $20,000 at that point. So that practically is just, really big considerations for doing this testing prenatally. These are the three labs that offer commercially available tests in the United States. It's available at GeneDx, Ambry Genetics, and Baylor Maraca. And these three labs have tests available for ongoing pregnancy. But what's interesting to me is they all regard ongoing pregnancy versus a terminated pregnancy differently. For example, GeneDx will not bill insurance for exome sequencing in ongoing pregnancies, but they will bill insurance for exome sequencing in terminated pregnancies. So that's unique. I can't totally explain the rationale for that, but it's true. Baylor, I believe, does do insurance billing for terminated pregnancies, but I wouldn't be super optimistic about the coverage for that at this point. And I don't believe Ambry offers insurance billing for their prenatal samples either. So this is a comparison of some of the factors between the different labs. I wasn't able to get complete information on Ambry's product, but all the labs are advertising about a 3 to 4 week turnaround time. Parental samples are required from GeneDx and Baylor. I mentioned a little bit about the cost. So the out-of-pocket self-pay price at GeneDx is $7,500. And that's a big old number. And I got the price from Baylor as well, actually right after I did this presentation and seminar, and it's $7,000. Both GeneDx and Baylor will take samples for ultrasound anomalies, and for both of them, you need to do a phone consult with one of the lab genetic counselors before sending a sample. And then these are some of the reporting nuances between the labs. So I know this is a very busy slide. I did use a lot of shorthand on this slide because it is so busy. But this just shows the importance of making sure that both the provider and the patient read the informed consent. And if you look up the requisitions for prenatal exome from any of these labs, they are very long and very, very detailed. But in this case, the requisitions are really not paperwork. They are really providing clinical information that's necessary for the interpretation of this testing. So I'd just like to highlight a couple differences here. GeneDx has both targeted and comprehensive options. Basically, with their comprehensive option, you're getting the potential for more uncertainty. So, regardless of which prenatal exome you order from GeneDx, you're going to learn about genes that are related to the phenotype and genes for significant childhood onset disease. And you'll get information about suspicious VUSs, but with the comprehensive option, you'll get all that plus variants of uncertain significance that are potentially related to the phenotype and variants in novel candidate genes. GeneDx has opt-in or out for the ACMG secondary findings, of course. And they only report on carrier status for the proband, aka the fetus, or the parents if it's related to the phenotype. So this is a lab where the two parents that you send in are definitely there for support. It's not quite like getting 3 exome sequences. It's like getting 1 exome sequence with 2 supporting players. So it's important that the provider is clear on that so that they can inform the patient of the information that they're getting. Because if a parent is part of a trio, and then later in life a need arises where genetic testing would be appropriate for them, for example, if they were to get a cancer diagnosis, it would really be off the mark to say, oh, I've already had exome sequencing and it didn't show anything. And from GeneDx, you get 1 report at the end of it, and that's the report for the fetus, and any relevant parent information is included in that. From Baylor, it's a little bit different. So the results you get from Baylor are pathogenic variants and variants of uncertain significance in genes that are related to the phenotype, as well as variants in disease-causing genes that are not related to the prenatal indication, but that are predicted to cause childhood onset disease. Their ACMG secondary findings are also available as opt-in, opt-out. They will report on carrier status for genes that are recommended by ACMG or ACOG. So, for example, cystic fibrosis, they'll report on if the proband or the parents are found to be carriers. Interestingly, because of the limitations of exome sequencing, 2 carrier statuses that they won't or can't report on are spinal muscular atrophy and Fragile X syndrome. So again, we need to be really careful in our thinking about this being the test for everything, which it's not. And from Baylor, there's a main report, of course, so related to what was found in the fetus, and then which parent any of those findings were inherited from, including this. I don't believe that actually includes the secondary findings, because where Baylor's a little different is that they will issue parental reports with secondary findings from the parents, but they'll only do that upon request following the end or after the end of the pregnancy. So their secondary findings will only be released after the pregnancy is complete, whether that be through the birth of the baby, termination, fetal demise, etc. And that I don't know if that's their way of kind of dodging the ethical issue of a family-changing pregnancy management based on a secondary finding or an adult onset condition, but that's how they structure things. At Ambry Genetics, one difference with their reporting is that they have 2 sets of diseases that parents can opt in or out for. They'll report on the findings that are related to the fetal presentation, and then you can opt in or out of childhood onset diseases that are unrelated to the phenotype, and in or out of the ACMG secondary findings. Another thing that Ambry offers that's interesting is they offer to give the proband, or maybe the proband, but definitely the parents, the option of expanded secondary findings, and you can find that rather long list of diseases that are included in their expanded secondary findings. but they do charge an additional fee for that expanded secondary findings panel. And they issue 2 reports. They issue a primary report, secondary report with secondary findings for the proband and the trio members. And then if you want to and are willing to pay the extra fee, the expanded secondary findings. All right, so let's dig into a very recent recommendation about prenatal exome sequencing. This timed out so well with me choosing to do this topic. This was a joint position statement issued from International Society for Prenatal Diagnosis, Society for Maternal Fetal Medicine, and Perinatal Quality Foundation. And it's actually a little surprising to have something that looks like recommendations on this technology so soon in the game, but it feels good. First and foremost, they say routine use is not recommended, which made me laugh a little bit because I thought, who is advocating for routine use? Hopefully no one. And they say that ideally prenatal exome testing would be done as on a research protocol, not on a clinical basis right now. But then they go on to say that you may consider non-research testing on a case-by-case basis and give you some guidelines for that. So their position statement reads a little bit like sex ed for teenagers, where they kind of start out by saying, the equivalent of don't have sex. You may consider having sex. If you're gonna have sex, these are some of the things you should do. That's kind of how their recommendation plays out. So some recommendations they make, they say that it's definitely best done as a trio, which is absolutely true. They also support that the genotype-phenotype correlation is often very limited. They state a couple things that are uncertain at this point, which is always feels a little futile when recommendations tell you how uncertain things are. So they say that right now it's unclear whether a multi-gene panel or a genome-wide interpretation would be best for prenatal testing. And they say it's unclear whether interpretation of variants should be the same as for children or adults, or whether restricting it more is preferable in a prenatal setting. And of course, they say that the provider who offers it should have a deep understanding of the risks and benefits. They give some extensive points about pretest education and informed consent. They reiterate that pretest and post-test counseling are essential. The list that they give, if you pull the original statement, is very good. I feel like if I consented for prenatal exome again, I would definitely refer to that list to review some of the points that they highlighted. Some of the things that they point out is that consent should be individualized, that it should be done with both parents when possible, and that each parent should provide consent. They do point out that in a pregnancy, it is the woman's prerogative to consent for a prenatal procedure. So a woman who wanted exome sequencing wouldn't be required to have the father's consent. But as we saw from the commercially available tests, at prenatal exome on a non-research basis right now does require both parents. So practically both parents are needed. Pretest counseling should include things like variants of uncertain significance and secondary findings. And then on the post-test side of things, the post-test counseling should utilize the decisions that were made in the pre-test counseling. So decisions about what the family wanted to know, whether they opted in or out of certain findings. And they also say that the post-test counseling should occur regardless of whether or not the sequencing has yielded a diagnosis, and should include discussions of parents' reproductive and testing options from there. The people they outline as appropriate candidates for considering this testing, there's a few surprises for me in here. They start out by saying a current pregnancy that has a fetus with a single major anomaly or multiple organ system anomalies suggestive of a genetic etiology who has either negative microarray or where a microarray was not done, but where the fetus has a strong enough pattern of anomalies that you suspect a single gene condition. The thing that was a little surprising to me there was saying a single major anomaly. I think of a fetus with a congenital heart defect and think, is that really the kind of fetus I want to throw this whole exome sequencing at? Not really, because I don't think we'd throw whole exome sequencing at a baby who had an isolated congenital heart defect. They go on to talk about families that are having recurrence of prenatal findings in pregnancies. So a family with an undiagnosed fetus that has anomalies and is having recurrence in this pregnancy, or a family with recurrent stillbirth who has a current fetus that has the same pattern of anomalies. My biggest surprise was they say that when doing preconception counseling, where no fetal DNA is available and there's a history of that fetus having anomalies, that it would be appropriate to offer parents whole exome sequencing on both of them to look for recessive disease carrier status. And I think that's pretty unprecedented right now, and I don't know that there's really any literature about that. So that intimidates me quite a bit. And then they say there's no evidence to support using whole exome for any other indication prenatally other than fetal anomalies. From a lab standpoint, they support data and variant sharing. They reiterate how important it is to share clinical information with the lab. They actually suggest sharing images as well. So not just a summary of the ultrasound findings, but even consider sending the lab the images from the ultrasound. And they say that variant classification is best done by the laboratory, which, as a clinical counselor, I couldn't agree more with. I definitely want my labs to give me the variant interpretation. Although at the same time, I think that we could have a really interesting conversation about what the clinical provider's role is in sort of digging into any variants that come up to see what's been reported about them. One of my colleagues recently got a microarray with a variant of uncertain significance on it. The lab had reported that region of the chromosome had never really been implicated in human disease, but when she looked into it herself, she found that it had. So, would she have been counseling her patients best if she only had stuck with what the lab said? And they also say that the focus should be on pathogenic and likely pathogenic variants related to the fetal phenotype. So what this position statement's advocating for right now is a very focused approach in prenatal exome sequencing. And I would say that they're advocating for having a more restrictive approach with prenatal testing than they would for postnatal testing. So, in conclusion of my whole talk, thanks for sticking around. This is a long one. Fetal exome sequencing is emerging, and on the one hand, it does have a lot of promise, but on the other hand, it is very complicated. So, the promise is, in those families in the case series who did get a diagnosis where they would not have otherwise without this technology. The complication is in all the consenting and potential for uncertainty. And then it's sort of in the difficulty with how we would use this information prospectively. Those case series showed that when used in fetuses with congenital anomalies, the yield may be comparable to a postnatal population. And all this complexity definitely points to the importance of multidisciplinary teams. And of course, as genetics professionals, a genetics professional all but needs to be involved in this kind of testing. But I think the case series also point to how important having imaging expertise is in order to get the best clinical information for interpretation. And at this time, for all practical purposes, there is significant both cost and gestational timing barriers to access to this for most patients. And truthfully, in digging into this testing, I really don't know, would I tell a patient that this is the best use of their $7,500? I'm really not sure that I would. So we are definitely a very long way from doing this on a daily basis, thank goodness. But this is pretty powerful testing that has the potential to find answers for some people as long as we use it judiciously and wisely. So here are some resources to learn more about exome sequencing and prenatal exome sequencing. The bottom one is that joint position statement that I talked about at the end. The top one is that BSECR article that I said the online version has a really helpful graphic to help explain exome sequencing. And that one's not about prenatal exome at all. That's just exome and genome sequencing in general. Really good article if you're a genetic counseling student and you want to get a good foundation. There's ACMG has a policy statement on points to consider for informed consent for genome and exome testing. And then I did find the Gene Review's educational material on comprehensive genomic testing and multi-gene panels really useful. And then finally, these are the references for my case series, if you want to dig into that. But thank you so much for sticking around. I'd be happy to take any questions via email. Have a great day.